Thank you. Sean?
Great. Well, so nice to be here. And I was going to talk quite a bit about big data until I saw Louis' slide about what would happen if you mentioned big data. So I don't want to go the Pulp Fiction route. Just to say, four great presentations on what incredible accomplishments. I know that each of you has invested an enormous amount of time in each of these things, and I think they each would be worth a few hours of really getting the all the lessons learned. But just to get the conversation started, I was going to offer a few just a few sort of miscellaneous reactions. First reaction actually is to Mark Berger, who I always like to react to. But fortunately today, we don't have to resolve the RCT versus observational debate, right? We'll just agree to disagree on that. So, but it is interesting. I guess what I'd say is, again, from the case studies, there's clearly huge opportunities to advance the state of the art, in both arenas. So we don't really need to pick one or the other. There's lots of work to do on real-world randomized studies and registries and large databases, et cetera. So plenty of important work to do in all those areas. A couple of things that I think are strike me as important are the sorts of things that I work on is and partly building on Rhonda's comments. I think while many of these conversations around real-world evidence tend to occur with a largely regulatory focus, it's clearly important that what I like to call the post-regulatory decision makers are part of the conversation about what kind of evidence is generated. And by post-regulatory decision makers, I mean not just payers, but formulary committees and guideline developers and health technology assessment organizations. Because, well, she's not sure what I said. Let me start again. Usually people say that in private after I've finished. Yeah. So I think that's probably it. No, I just because again, while clearly a major user of real-world evidence is for regulatory decision making, increasingly this is kind of evidence that's going to be factored into health technology assessments, formulary decisions, value-based pricing, et cetera, et cetera. So if those decision makers are going to be involved in assessing the quality and relevance of the evidence, we ought to find better ways to make sure that they're also involved in these conversations about how the studies should be done and talking about the quality of the data sources and the methodology, et cetera. We have a whole field that we call regulatory science, which is talking to the regulators about these issues. I'm promoting the field of reimbursement science, which is where you bring the payers and their advisors into the conversation. I won't say much more about it, but I think this whole issue of what is the incentives for frontline clinicians to participate and to gather high-quality data, whether it's on enrolling patients, getting meaningful information on patient sort of patient health status and other things that the richness of data, whether it's prospectively from a prospective study or retrospectively analyzed, is only going to be as good as what the clinicians are going to enter, or we talked about natural language processing. But I just think on the front end, having animated clinicians, who are participating, and then you have to ask the question of well, what's in it for them, right? It seems like everybody else is figuring out how to make money in the field of real-world evidence, but the docs are just supposed to do it because it's the right thing to do for the patients. And we might want to think more about what's in it for them that's real and meaningful, and maybe it comes down to something like paying them, but I think there's a lot of other mechanisms. And in fact, we just got a grant from PCORI to look at the whole question of clinician engagement and what impacts clinicians. And then the last point I want to make is just about, still on this kick about the importance of harmonizing or standardizing or coming up with some patient-relevant core outcomes for different therapeutic conditions. You probably know, even in the setting of asthma, there was a recent consensus conference where they looked at patient-reported symptoms in asthma and decided that none of the available instruments are adequately validated for common use. So And you may want to comment back on that. That's what I read most recently from a 2012 report from some work that Jerry Christian and his group did. But the point is, if we're going to be, extracting information from data sources or doing pragmatic trials, et cetera, and want to do, in some cases, indirect comparisons, if the kind of information we're limited to doesn't capture the full range of what's important to patients, then I think we're just not going to end up with as meaningful information as we otherwise would.